Okay, that takes us under presentations for general information to 7B, the El Paso County Health Update. And I think as we mentioned earlier, we're going to kind of focus today on the update concerning COVID. And we're lucky to have Susan Whalen, the El Paso County Health Director, and Robin's with you, I guess. And we're going to probably see Dr. Kelly at a later meeting talking about the coroner's report for 2020. So with that, Susan, welcome, and thanks for being here and being patient.
Good morning, and is it on? There we go. It's green. Okay. Dr. Kelly actually was going to join us this morning, but unfortunately, he is quite busy this morning and had to hang back. But I think we're working towards maybe June 7th.
Yeah, we're going to, and I think we'll probably work toward another, rather than the lunch that I talked with you about, probably another work session so that we can get more publicity, more people watching, and have it televised. So if that works with you, that's what we'll shoot for.
Yeah, that would be fantastic. So thank you.
Okay.
I first wanted to start off that this is the first time that I'm here with no mask. And it feels very refreshing. I will say that I'm fully vaccinated. My family is fully vaccinated. And I was so happy to do so when the time was right and we had the vaccine supplies to do so. I just got my 15-year-old vaccinated. She got out of school on Friday, and logistically it was just easier to get the vaccination on Saturday. And she's not experiencing any reactions, and just very, very happy about that. And that's what we're here to talk about, is the vaccine distribution. I've been before you all numerous times before, and have appreciated your leadership and the working relationship that we have. And I did want to congratulate all of the new faces and new council members that I see here today. And I know one is on screen. I really look forward to working with you, and would also offer up if you wanted to get more information on public health and maybe have a one-on-one session or I don't know how many of before it's a quorum with yours, two, but there's a lot that we do as well in public health, and would welcome the opportunity for that connection with me and my team. I also wanted to say that it is so nice to see the leadership of AICTA. She's a powerhouse, and we've worked very closely together. And she's also, we're a class of 2018, Colorado Springs Leadership Institute with Sarah Johnson.
Is that the best class ever?
It is the best class ever. That's what we all say, right? I know Richard Scorman and Jeff Green are also CSLI graduates as well. So let's go ahead and get started. We're here to talk about some good news, and I think that where we've been this 15 months, it's feeling great, and the numbers are looking good. I'm here today with my team, Dr. Robin Johnson, who is our medical director. I have members of my data analytics team, our chief scientific strategist, Stephen Goodwin, and our lead epidemiology with the data analyst office, Fadi Yokohana, as well as we're going to talk about some policy today updates. Diana May with our attorney's office is here as well. And like I said, Dr. Kelly was going to join us, but he is not available, and I wanted to make sure I wasn't forgetting anyone.
They're coming up to back you up.
Yeah, and please join me, and I'll just go ahead and stay up here as well. I'm also coming before you to ask for your help. We still need help to make steady progress in our community. Our highest day of vaccinations were on April 11th, which were 48,900 vaccinations. And we are still making slow but steady progress at over 20,000 vaccinations per week. And we have changed our strategy, and we'll talk a little bit about that. And I also wanted to thank Yolanda Avila and also Mayor Southers, as well as Brett Waters, members of your communication team, Kim Melkor, and Jamie is Fabos is as well, because they have been really engaged and dedicated on the vaccine consortium, and they have helped us move through the different phases when we didn't have, vaccine resources were not plentiful nationwide. And so all along the way, we've had to ramp up and change our strategy. So we'll talk a little bit about that, but wanted to thank them because they have been heavily engaged and helping us to come up with strategies and also build trusting relationships within the community. And so we'll talk a little bit about that as well. So with that, Fadi and Stephen, if you want to go ahead and kick us off with a data update.
Good morning, everyone. Beautiful morning, beautiful Colorado morning. I'm not sure if I'm ready to call it a summer morning, as I understand.
And if you would introduce yourself and please tell us your position.
Sure. My name is Fadi Okana. I'm an epidemiologist. I work with Stephen in our Office of Data and Analytics at El Paso County Public Health. We'll be tag teaming a brief overview of current trends, how the numbers look in terms of COVID and vaccines. Next slide, please. And the following, please. And we're very familiar with Teams and how long it takes, so we appreciate your patience with us. As Susan mentioned, there have been some evolutions going on with our vaccine campaign. We like to categorize it in 3 different categories. The first is a supply constraint. That was the case in December and early January. If you remember, we were following a phase approach, and that was consistent across the nation. The reason for that is because we wanted to vaccinate those that are vulnerable first while we wait for backup with supplies. As supplies started to become plenty, we moved on into a capacity constraint. Our vaccine consortium met weekly, and we discussed and planned and executed plans to make sure that we have different types of vaccine points. So we had a large vaccine clinic, we had a small clinic, a pop-up clinic, whatever is needed, we were working on it. And now we're moving into the third phase, perhaps the most complex, a demand constraint. How do we answer questions about those that are hesitant? How do we make sure that we have resources for those that want to find out more about the vaccine? Next slide, please. There are 2 goals that you may have heard of. The first is a national goal, both around July 4th, Independence Day. The first goal, the national goal, is to hit 70% of adults in the U.S. with at least 1 dose and about 63% fully vaccinated. The state goal is a little bit more aggressive. It's a 75% mark of the eligible population. That's a larger denominator than the state goal because it includes eligible participants, not only adults. There are about 43 days from now until then, and we're at 53% vaccinated in El Paso County. Next slide, please. Our current trends, we did experience a bit of a downward trajectory for the late April, early May. However, as you can see on the graph, we're showing our first page of the vaccine dashboard that's available publicly. The highlighted line there, you see a little bit of a downturn and then a bit of a spike. That spike is very exciting. It's recent, and we hope for that to continue as we vaccinate more and more people. I just want to point out that the goal of 75% by July 4th, it's a number, it's a statistic. Sometimes we can get lost in these percentages. More than 50% of the eligible participants in El Paso County have been vaccinated. That's 1 in every 2. Very important to recognize that so that we're not stuck in this binary fail-pass environment. Next slide, please. When we do compare El Paso County to other counties in Colorado, the graph we're showing right now is of the largest 10 counties in Colorado. Unfortunately, El Paso County ranks in the lower bottom of that top 10. We are very fortunate here in El Paso County because we have active communication with our federal partners. That's not the case with all counties, and sometimes not even the case with state level data. With our federal partners, we're at 53% vaccinated, and that ranks 7th ahead of Pueblo and Weld. The way that the goal is set right now, it's unlikely that at least half of these counties will meet that goal. So this goal may be aligned with the national goal. We don't know that yet. We haven't received any communication. Right now, we're operating on the basis that it is a 75% eligible population by July 4th.
Can I ask a question here?
Sure, Wayne, go ahead.
So if someone's gotten the vaccination federally,
yes,
there is absolutely no reason for them to get them a second dose of vaccination locally, correct?
Yeah, I'm not following
Okay,
it.
so let me. So you've got a chart that has one number, but then you say, but really there are other people who've been vaccinated and we're not counting them And my question on that is, it would be ridiculous for that person who's gotten a vaccination through their federal service to then go out and say, well, I need to help the numbers here, so I should go get a vaccination locally, right?
It's very unlikely that someone would double dip, where they'll be counted twice in the federal numbers as well as the state numbers.
So why don't we include them in the chart? Because they're just as vaccinated if they got it at Fort Carson as they are if they got it at Memorial.
Right, and if I may clarify that orange line, that's only state data. The dashed line is where we're showing the federal inclusions as well. It's all about data access. And
so when the state issues a report that says El Paso County is less, that's because they're not including the large federal population we have here, and they're just flat out wrong.
So that would be true for all of the counties, though, correct?
But other counties don't have the large federal population that we have in the military.
Since we have probably the largest population of military installations and bases in El Paso County, we formed partnerships with our military partners, and also Mayor Southers has connected us through his Monday meetings, and through those relationships, they're providing us their data, but the data that we have access to openly is the blue lines. And so we're showing the blue lines up there, and that's what we have access to. But the state does not count federal supplies in their numbers, but we feel that it's important that we show in El Paso County, that's what we believe the percentage to be. So it's a matter of who has access to what data.
Okay, I appreciate that. I very much appreciate your working to add that data in, because I think looking at what the state has simply provides an inaccurate picture. There's still obviously more we need to do with respect to vaccination, and I encourage folks to get vaccinated, because it makes us a safer community, both for themselves and for those around them. So let me be clear on this, that I support that, but I don't support telling us we need more people vaccinated is accurate. The state saying we're dead last is not accurate, because they're not including a significant portion of our population. I have been frustrated with the state's reporting on other issues as well on this, where they have not done the job they should have done. So, but I'm glad you are, so thank you.
Yes, and I will say that our military partners are also part of the El Paso County and Colorado Springs Vaccine Consortium, and we have been meeting on a weekly basis. We're going to a monthly, but our military partners are very engaged and very participatory in El Paso County.
Also, if I may, Stephen Goodwin, Chief Data Scientific Strategist, this is a national problem. And the state of Colorado is moving to incorporate federal data along with other states. It's just that they're late to the game. So it is a data challenge, not a physical challenge. But you're absolutely correct.
Let me, and we'll be a little interactive if you don't mind.
I love that.
So Stephen, Foudy, and Susan, Bill Murray's got a question, it looks like, about the India variant. Are you going to talk about that, maybe, or some of the other variants in your presentation today?
We go ahead.
We have our wonderful medical director here, and she'll be coming up to talk about some of the slides that Dr. Kelly had intended to present.
Yeah, we don't have to jump in now, but I just wanted to mention that question from Mr. Murray talking about the India variant. So,
yep. And there are several coming out of India, but one of particular.
So you want to continue, Foudy? Yep. Yep, Dave.
The question just on this same topic. When you speak to the news, like television, radio, do you always point, or I would ask you to, can you always point this out, that if we include the federal injections or federal data also, our percentage is 53%? Is that something you do already, or is it something you can do?
David, if you can kind of talk into your mic, you're a little quiet, believe it or not.
Yeah, I thought I wasn't supposed to get close. All right.
Yes, we do, and we do provide that publicly as well on our dashboard. And that was part of the whole motivation behind it, is that we wanted to paint a holistic picture of the activity in El Paso County.
And we also offer vaccine distribution highlights on a weekly basis, and we mail those out or through email to, I'm hoping, all council members.
We do.
And all of that information is in there, and so we do include those numbers. And I like your inject those numbers into the, and yeah.
Richard Storman's got a question he would like to ask now. John, I'm sorry.
The issue about the military being vaccinated, isn't there a hesitancy with the military as well? And it's fairly significant because I just hear that anecdotally, but I don't know for sure.
We can talk a little bit about that later if that's okay. We do have some survey information because the big question is the whys behind the hesitancy and then how we change our strategy to meet the needs.
Good. So Foudy, if you want to continue, I think we're clear for a while.
Okay.
Also, if I may, the federal entities that are involved in the lack of numbers are both the DoD, the Veterans Affairs, as well as the Bureau of Prisons nationally. So that's for the missing data sets. So what we're showing now is a slide. If we can go ahead and move to the next slide. Chief Data Scientific Strategist. I lead the Office of Data and Analytics at Public Health. Work with Foudy. What we're showing now is a slide that shows the time story of vaccinations by age cohort. And this is really important to understand. Initially, when we were driven by supply constraints, the first people to get the vaccines were working in basically medical care with high risk of being exposed. And then very quickly, they moved into long-term care facilities for both residents and the carekeepers, and then more widely into the medical community. So initially, the age demographics of the people who were being vaccinated were people in the medical professions. After we opened up the long-term care facilities, and then we began this, and it's hard to imagine it was so long ago now, it seems like another era, we began this rollout of vaccine by risk, fundamentally in the United States of America. So the chart that I'm displaying actually shows that graphically, and you can see that effectively the biggest risk for this disease is your age. The older you are, the more likely you're to have a negative outcome with COVID. And so you can see the numbers just really demonstrate this dramatically, so that the older cohort now is more than, again, this slide is only containing information from the Colorado Immunization Information System, so it's missing federal data, but it's showing here that we've got about 78% of the 65 plus demographic vaccinated at this time with at least one vaccine. And at the bottom end of that, you can see the 12 to 39 demographic, about 30%. So it follows very closely, and you can actually see when the different eligibility occurred on the charts, and then you have this upward demand. Also, these demands are characterized by this demand that we've talked about. If there was pent-up demand early on, we would see this activity very rapidly, but then it begins to chill and moves into asymptotic, which is what we see now. Let's go to the next slide, please. Another way to look at the age demographics is really important in terms of our vaccine program here is on this slide, we've added one new dimension, and that is the population. So in blue are the size of these age demographics. In maroon are the number vaccinated. And then in the back, we have a dotted line, again, showing the same percentage. So you can see where we need to be vaccinating, which makes complete sense given the way the vaccines were rolled out. And that is fundamentally among the younger age demographics. Of course, our goal is to continue to protect those most at risk, to make sure that particularly those in the older demographics still have access and take advantage of being vaccinated. But in terms of achieving these numbers that are going to slow down the spread of the virus by having fewer susceptible individuals, our focus, our target is really the younger demographics now. Again, logically because of the way that the vaccines were made available, and also logically because people in the younger demographics tend to see the disease as less of a personal threat. Next slide, please. The wonderful thing about these vaccines is that it's been the most amazing advance in medical science to put out the vaccines that we currently have. We have 3 wonderful, extremely effective vaccines. Again, because of the way they've been rolled out, they were initially in a supply constraint mode. We see that vaccines are our primary tool to fight this disease going forward. And we see that they're working, which is really exciting. Even using El Paso County data, we can see that they're working quite well. With more than 75% of our 65 plus group vaccinated, we can see that hospitalizations in that group are falling away. We still have elevated hospitalizations because we have relatively high incidence. The state of Colorado is sort of in a high plateau, and now luckily we're falling along with the United States of America, which is fantastic. But there's there's still a way to go. Prevention and mitigation strategies are still going to remain effective, particularly into the future for outbreaks and surges, and especially for those people who are not vaccinated in the present. Remember that everybody can't be vaccinated. That's an important thing to understand. Next slide, please. Some of the evidence that things are working, the vaccines, I should say. So what I've got here is a dot plot that actually shows the current incidence of disease, and that's measured in a 1 week incidence. This is public data from the state of Colorado against the percentage vaccinated. Again, this is only using CIS data. So this is only using the state of Colorado data. But what you expect to see is that the more highly vaccinated a county is, the lower their incidence will become over time. We expect this to become, one of the single biggest predictors of disease activity. And in fact, you see in this chart, sadly, that on the vertical axis, which is showing us the 1 week incidence, El Paso County rates very high just from this other chart. Now, if we include federal data, we would be moved down on this chart. And then left to right, what we're actually looking at is the percentage of population vaccinated. You can see some counties are above 70% eligible vaccinated. So it's a pretty striking graphic and one that we'd expect to see. Next slide, please. Here's another way to look at data, and this is only, the first slide was from the state of Colorado. This slide is also through the state of Colorado's data system, but this is for hospitalizations within El Paso County. And again, this is a dramatic demonstration of the effectiveness of vaccines about keeping us from getting seriously ill. You can see the three lines by age demographics totaling to 100%. You would expect 65 plus, because of the nature of this disease, to be the most hospitalized. But since the advent of vaccines, that cohort has fallen in terms of their percentage of hospitalizations, and the younger patients who are still in our hospitals, we have elevated census now, are becoming ill. So really what's happening is, with vaccines and the way that we've delivered them, this has become a disease of the younger population fundamentally. So it's actually a quite astonishing demonstration of this. You ask about vaccine hesitancy. Next slide. This is really important construct, and nationally, there's a very well-respected organization, the Kaiser Family Foundation, who has a study, and they're actually going out there and doing it every month. And it's just been a fantastic resource for us to understand the hesitancy, and I use that word guardedly, but to understand why people choose to become vaccinated or not become vaccinated. And at the bottom of the chart, it shows you the first survey they did before the vaccines became available, really. It was done in December. And the fascinating thing here, and the thing I find very useful, is it divides people into four groups as regards vaccination. Those that are going to get vaccinated as soon as possible, those that are going to wait and see how things work out with the vaccines, and there are the others that only if they're required to become vaccinated, or those who are just definitely not going to become vaccinated. So it's a fascinating way to think about how people make these choices with regards to vaccines.
Do you know the age that they surveyed?
These were across a basket of ages. So in fact, they looked at and I really recommend the survey highly, and they're improving it over the months. So they're looking at age, they're looking at economic class, they're looking at all kinds of different factors. It's quite fascinating. But this is really fundamentally important to understand this grouping, I think, as we address this into the future. And the really fascinating thing is, as you go up the bar now, you start to see, as the subsequent months, some people have become vaccinated. And what's fascinating and encouraging is that the as soon as possible are getting vaccinated, which one would expect. That is a bit of a no-brainer tautology, right? But the ones who are wait and see, they're getting vaccinated. Only if required, they're beginning to get vaccinated. The definitely nots are definitely not. So it's really kind of a fascinating look at the data going over time. And we hope to learn more from this. And again, it's national and a really nice survey. And we want to be able to apply, of course, this to our local circumstance. Next slide, please. Andy, do you have a question?
I did. So in terms of that slide that you were showing.
Sure, we can move back to it. Yep.
Thanks. So as we look then at the national data, and presuming that El Paso County has similar people in similar groupings, although perhaps more in some than others, basically you've got roughly 20% of the population that says we're not interested in being vaccinated unless someone tells us we have to, and some even not in that circumstance. And at least nationally, you've got about a quarter of the population that isn't, but is willing to. Is that so? In terms of, and you may be talking about this shortly, so if so, just tell me that. In terms of reaching out to people to encourage folks to be vaccinated, spending a lot of effort on the ones who say no, and perhaps more strongly than I just said it, doesn't seem to make a lot of sense. But there is a large cohort that isn't, that is willing to be, whether it's a wait and see or an as soon as possible category. Does this survey get into what would persuade you to do it then?
It's quite fascinating. I mean, you're talking about elasticity of intent, perhaps, right? So you're right. You're correct, and I think that's your point is right on. The people who are definitely not going to get vaccinated are not the people that we're going to influence, and in fact, we may just irritate them. And we don't want to be irritating. We're already irritating enough. I know you're not tired of hearing from us, but that's exactly right. So the strategy is really to try to find the messages and try to find the changes that are going to influence others. And one of them will be when the vaccines achieve full approval. And, you know, the first vaccine to come out, of course, was the Pfizer-BioNTech vaccine, and they have since now applied for full approval. So that process will unfold, and that will remove additional barriers to adoption. I'm sure the Moderna vaccine, as they are accruing, again, they're a little bit behind in time, will also be going in for full approval. And that's one thing I think that's going to help businesses, organizations, as well as individuals who are making this decision. But you're absolutely right. You are dead on. That the hard over not going to get vaccinated, I'm not sure that the messaging is going to be positive in that space.
So if we focus that and we get the 80% that are interested, we get the approvals, or we make it easier to get without an appointment. We have it. We emphasize that it's free. There's no charge, and all of these wonderful things. At 80%, what does that mean in terms of our ability to function as a nation on airplanes and everything else?
Well, the higher the better, and 80% would be an awesome number. And I think we are seeing tipping points at less than that. Again, this is a disease that we're still trying to understand, but certainly 80% vaccination rate would be astonishingly excellent. And by the way, the other challenge we have is for 2 of the 3 vaccines currently authorized for use in the United States, it's a 2 vaccination series. And one of the challenges that we have is for people to understand that, number one, for optimal personal protection, we want them to complete both vaccinations in the series. And 2, that there's a delay inherent in the vaccination process, so that after you've been vaccinated, there's a period of time while you mount an immune response. And canonically, we just use 2 weeks as that period of time, which helps people think about it. But I think it's going to help us all, and it's going to be a fundamental change in our behavior. And ironically, some of the countries that have done very, very well at reducing COVID and just never had to deal with it are in a rougher spot now, ironically, because they don't have vaccinations in play. And when you introduce and open up your society and more exposures occur, you really do depend on this kind of resistance. Having either been exposed to the disease, which is not what we recommend, and become infected, or having been vaccinated. And again, they're starting to see some logistical challenges with opening up these countries, which is quite fascinating.
Yeah, please continue.
I think we're at the
We're really at the Susan Whelan.
we're actually at the strategy slide, and I think your question really leads well into, you know, where are we now? Because everything that we are doing, and the we is a big we with the El Paso County and Colorado Springs Consortium, which is made up of the 3 hospitals, UC Health, Penrose, St. Francis, Centura, and Children's Hospital. All of our pharmacies, our smaller primary care physician offices, some of them like Matthews Fu, our military partners, and I'm sure I'm forgetting some folks on there, but it's a very great group of minds to where we have been making a lot of collective progress. And our whole goal is to vaccinate as many eligible people as we can, spending energy where we are going to produce some results. We go out and we educate and we provide information, and then we provide access. And the access points that we have, tremendously ramped up from, it was mid-December when we first got our first vaccine supplies, and ramped up significantly with the mass vaccination sites and got that going. And then, we had some challenges as it relates to some of the just the vaccine supplies, and we got that situated. And then now we've really transitioned into having over 100 different access points throughout El Paso County. And we have went through a low barrier to a no barrier approach, which means that you don't have to make an appointment at many of these clinics. You can do a walk-in. And then it was announced last week that providers, very afraid of wasting doses. Now the strategy also is, if you have people that are interested in getting vaccinated, you can puncture those vials to vaccinate the people that are ready to get vaccinated. And there's also some strategies to eliminate waste, but we're in a very much different place. And so what I want to touch on where we are now with our primary strategy of focusing on where we can reach people to where they are, the folks that are logistically, they might have some challenges. I know that some individuals that want to get vaccine, that they need some help from their employers if they're afraid of getting some reactions afterwards, and being away from work or having that time off. There are some people are just kind of the wait and seers. And so we are trying to make access as easily as possible. So we are investing in working with trusted partners and reaching out to people where they are. And so what does that look like? And that's where I would like your help to continue making progress, because you are trusted in the community as leaders. And then also, if you have additional ideas on top of what we're already doing, we would welcome that, because we want to catch people at the right time, the right place, and offer the vaccination if they're willing to be vaccinated. So we, this past weekend, we were at the Switchbacks, their opening game. And so their leadership, we connected with them and asked them if they wanted a mobile vaccination van. And, some of those numbers are pretty low, but we did make some progress. And I think 5 players got vaccinated, and a handful of members of the public. But that just shows that we're out and about and offering access to those that want the vaccination. We are at Our Lady of Guadalupe, and what that consisted of was vaccinating, I believe, around 70 people. But we worked with the pastor and provided education at some of the services. And again, working through those trusted relationships, and then providing the mobile vaccination van to accommodate people and meet them where they are. We have a number of different mobile vaccinations that have already happened at different school districts. I know that we offered 300 vaccinations at Cheyenne Mountain School District. About 130 of those were second doses, but then as we opened up the eligibility to younger age groups, then we offered those vaccinations to the younger age groups. We are working with Sierra High School, Harrison High School, Vista Ridge. I mean, I have a long list of where we're going out to. We did the First Friday downtown. There's so many partnerships and trusted relationships that we've been working with. And that's really where our strategy is now, because what we're finding is that we have all of these access points, but people need the right touch, the right focus, the right trusted source to help them get vaccinated. And we also are finding out that people trust their primary care doctors. I don't think that that's surprising, but some are waiting to have their vaccination in their primary care office. And remember that when you puncture those vials, it's not just a handful of vials. So it's logistically, it was very challenging for the storage some of the ultra cold storage, and just logistically, it's gotten a lot easier. So we're able to open it up a lot more as we move down the path. And I do know that there are incentives that are being considered. And now, what will those look like? I know you hear about the lottery, and I think Ohio, and all
What do
these
you think about that?
different aspects. Well, I'm that's a lot of money, so I'm not sure where that's going to come from.
What was it, $1 million in Ohio?
Yeah, and so I mean, I had heard that it increased vaccination rates by 28%, but what's behind that data and all the details, I don't know. But that's what I'm hearing. I do know that the governor's office is currently evaluating. I don't know about the lottery, but I do know that there will be some incentives that will be coming forth in our community. I can't promise $1 million, vaccination opportunity, but so that's where we're moving. And so any input, or I just really, appreciate your leadership and helping us move down this path, because it's not magic. This has taken hard work. We're trying to vaccinate as many people as we can. And I commend the action on the public's part, because the more vaccinated people there are, it gives the virus less opportunities to find a host and infect and spread. And that's really, it's not necessarily, it's about individuals and about protecting our own health, but it's also about blanketing the county for community health protection. And so I think that we are making a lot of progress. I know that we all would like it to go quicker, but this is where we are. And I feel really good about the progress that we are making. It just means that we're going to meet our goal at a later date. And we're in the same boat that many other counties are. But I do want to underscore all of the hard work of the people on the vaccine consortium and everyone in the community. We will probably today, and I'm going to predict that we're going to hit over 500,000 doses administered in El Paso County and all the cities within today. If you include federal supplies, we're well beyond that already. But I think that that's significant when you think about the logistics of these places doing the vaccinations, that they weren't these powerhouses before, these hospitals and such. They have really risen to protect our community. So I think that has to always be underscored, because it has taken some really hard work and collaboration and coordination to get our community to this point.
Also, if I may, one of the real challenges, of course, during this pandemic is we're learning on the fly, and people don't necessarily like to watch science happen on the fly. But the news that we're accruing about the effectiveness about vaccines is particularly exciting. I mean, initially, we had high confidence that they would reduce illness and deaths, but they're also helping to reduce onward transmissions. They're going to become a fantastic tool to help suppress the spread of the virus. And viruses are evolutionary like water. They find that lowest lying point, and they find their way to those susceptible host organisms. And so we don't want to be that county. So that's why it's so exciting that we're making such progress.
Okay, any further slides?
We do have a couple of slides of some beautiful lungs and what COVID can do on your body a little bit later. But we're going to do a policy update, because I know that there has been so many different reports and such, and I know that we send out an overview and a summary of that, but we do have our County Attorney Diana Maida to just go over the highlights of where we are.
Well, welcome, Diana. Thanks for being here. And we're going to hear about the variants.
Yes, and we're going to, Dr. Johnson is going to go much more in depth about the variants, and then also has some impactful slides related to what COVID does to the lungs.
Well, welcome, Diana May.
Good morning, Diana May, County Attorney. Good morning, everyone. I'm just going to briefly go through, we've been doing this presentation, just some of the legal updates. I'm assuming everyone knows them, but just to make it very clear, sometimes it gets a little complicated. Next slide, please. I'm going to start with talking about face coverings. General rule is they're not required anymore. And there's exceptions, I know, right? It was nice last Tuesday to be at my board meeting without a mask on. So this current executive order, and it's also incorporated in his public health order, expires on June 1st. Next slide, please. There's exceptions to the general rule, and there's 6 different categories that still require masks if you're not fully vaccinated or you're unvaccinated. And so those 6 different areas are listed on here. The big one that causes probably a lot of questions is in the schools. Thankfully, schools are almost out, and this expires on June 1st, so we're optimistic for schools that masks would not continue. We'll see. But these are the general exceptions to that. Next slide, please. And then there's what I call exemptions. The public health order isn't written like this, but this is my legal interpretation of that, which means of those 6 categories that I've just covered, there's different areas that they do not apply to. And they're listed on this slide. One of the big ones that probably people are familiar with is in a religious type setting and officiating a religious setting or present for a religious event. There are, and next slide please, additional exemptions that is incorporated that have been in effect, and I'm not going to go through all them, but a lot of them are, for example, apply to you all when you're public speaking or you're engaged in that public speaking. Those exemptions are still in effect. So basically, again, the general rules, masks are not required unless they're in those 6 different areas. Next slide, please. None of the exceptions or the exemptions apply to those 10 years and younger. And then just a reminder that businesses can always put additional restrictions on their customers and coming into their business. So that's a reminder that inherent is this ability for business owners to say masks are still required for you to, come into our business. Next slide, please. The next is the public health order. This incorporated the face coverings, but it also has some additional provisions. This again expires on June 1st. Next slide, please. As you're aware, the Public Health Order 38 first went into effect on April 15th, which got rid of the dial. El Paso County Public Health did not impose any additional restrictions, but there were restrictions originally placed on outdoor events, indoor events, and then there's a clawback provision. Next slide, please. With regard to, next slide, sorry. Schools, still in effect on schools, the regulations that were placed on the schools early in the pandemic. Nothing has changed with regard to that. Public Health is a very wonderful schools team that works very closely with both private and public schools in this community, and it has a very good collaborative relationship. Next slide, please. Outdoor events. So this went into effect when the mask order was changed the Friday before last. There was one restriction that was in effect on outdoors for seated, ticketed outdoor events over 30,000 seated, any 30,000 square feet. So this would have been this weekend's game, right? That was at the Vive Stadium. But this went away the Friday before last. So right now, there is no restrictions on outdoor events, whether it's seated or unseated. There's no restrictions on outdoor events. So that's, the big message to be heard. There's no restrictions there. The next slide, please, talks about the different distinction on indoor events. There's 3 different categories. There's under 100, 100 to 500, and then over 500. So under 100, the only thing that would apply is if there's any restrictions placed on the face coverings restrictions. But the general rule is indoor events under 100, there does not have to be 6-foot distancing. So technically in this room, the seats, you could put all the seats back in here if you so chose. To do that and have people seated right next to each other, because I assume there'd be under 100 people in here. So there's no requirement for that 6-foot distancing. When you go from 100 to 500, there is a requirement for 6-foot distancing if you have unvaccinated or unknown vaccination status. So kind of an example I like to use is if we're in Centennial Hall and let's say we have 200 attendees in there, and you can either assume they're all unvaccinated, right, or unknown vaccination, and make sure that group, that cohort is 6 feet apart, or you can choose to ask and say vaccinated can go over here. They can sit right next to each other. The unvaccinated need to stay, or the unknown vaccination 6 feet apart. That is an example that businesses can so choose if they wish. The next is over 500. At this point, there's a requirement that there has to be a variance from your local public health and state public health. But 5-star certified businesses and variances that are were approved by the state remain in effect. So the big kicker is 500 indoor. There has to be a variance. However, next slide, please. There's exceptions to that. That requirement for the variance is not, you do not have to get that variance for places of worship and associated ceremonies. For retail, what we call big box business, so Target or Walmart, you don't have to have a variance for 500. You don't have to have a variance for churches. Restaurants, you don't have to have the variance unless you have a unseated area where 100 or more people could gather. This is meant to get at dance floors. And then for schools and proms, I know this is a big week of high school graduations. Most of our graduations are outdoors, so this necessarily isn't applicable. Next slide, please. There is a provision in there that's important to keep in mind, and I call it the clawback provision. And what it indicates is that if there is a threat to 85% capacity of our hospitals locally, that the state could come back in and require, in consultation with Susan, additional restrictions put on our county. So that's, again, a huge reason why there's a collaborative effort between public health and the hospitals on sharing that data and that information to make sure our hospital capacity is not getting to 85%.
Let me go back and ask a question about one of the other things you mentioned. When you said you could have a separate seating area for vaccinated, which is compact, and unvaccinated, which maintains a 6-foot distance, is there any type of monitoring required or proof required, or would you simply say, we're excited to open city council meetings, we have room for 100 vaccinated people and 5 unvaccinated people, and then have the seating arranged appropriately? Is there any monitoring by the entity that's required?
Thank you for that question, Councilman Williams. So the public health order does not prohibit self-reporting. So that's what we've been very clear with businesses, is that it doesn't prohibit self-reporting. So a business could just simply ask people, or post a sign that says, if you're unvaccinated, you need to maintain 3-foot distancing on this side. If you're vaccinated, you may sit next to each other. So there's no restrictions. I know from a public health perspective, when I work with public health from an enforcement perspective, we very much try to factor in common sense and work with businesses on answering their questions and trying to educate if there's a question.
And then the exception you had, which is an entity can say, in our community or when you enter my building, please wear a mask, exists now with respect to an entity that says, please don't smoke while you're in my building, or please don't drink liquor while you're in my building, or any of those other provisions, right?
Correct. It's similar to what, at least I'm going to age myself a little bit, where we would grow up that said no shirts, no shoes, no service, right? So businesses can absolutely place different restrictions on their private business if they so choose.
Yeah.
But just to clarify for me, this would be on the honor system. In terms of people that say they're vaccinated, you're not going to ask them for their card. You're just going to say, if you're vaccinated, we trust you.
That's the advice that we've given out to businesses. We don't, because the governor or the state public health department has not imposed a certain verification process. Common sense needs to factor in, and so with that, President Strand, is we've just indicated to people that self-reporting is sufficient underneath the current existing.
Okay, you've made that clear. Thank you.
Yes.
And then the other question I had for you, there has been some concern expressed by folks with respect to the library district adopting a more restrictive access policy for the taxpayers of El Paso County. Are you familiar with that issue at all, or what they're doing?
I am familiar that there's some concerns out there about the library district's restrictions.
Okay, thanks.
Mr. Don?
This might not be a question that you can answer, but is it legal? You can ask anything. A business asks a person, have you been vaccinated? And they say, oh, that's private, I don't want to tell you. Is that it? Is the discussion over? Is the business can go no farther than that? Or can they say, well, then you can't come in?
I think inherent, again, in talking in general policy or general legal concepts, a business can always deny admittance to someone. A business could say, I need to see proof of it, or I need you to, sign a piece of paper that says you're vaccinated. I mean, businesses can choose to place their own internal requirements on entrance. We have, I don't think we're aware of any businesses going to that extent that I'm aware of. Are you, Susan?
I know that, I mean, there are businesses that, are requiring masks, and they are, checking at the front door, just across the board. And, when I walked into a grocery store, I want to be respectful. So I bring my mask, and sometimes there's good signage and sometimes there's not great signage. So I asked the question, are you wanting us to wear masks? And one of the individuals, the worker, said, well, are you vaccinated? I said, yes, I'm vaccinated. So I do think that, part of the common sense piece of this is that I would ask people to be respectful in different settings, because I do know people that have been vaccinated and they feel comfortable wearing a mask. And so I think that there's the public health order and the technical assistance that we're providing to the community in order to be successful. But, there's also, just with where we are, everyone feels comfortable. There's not like a one size fits all as it relates to some of the businesses requiring masks or not.
The mask part, I think, is pretty clear to people. But as far as, does a business have a right to ask you about your medical history, HIPAA? Can they delve into what shots you've had?
Well, and Councilman Donaldson, I'm not trying to not answer your question. I know lawyers oftentimes don't answer questions, but what I have to always make sure I do is stay in my own lane.
That's why I said it might not be a question.
So my lane is always to advise my clients or public health. And so when we have had businesses call, which they have called, what we've advised them to do is to seek some legal advice from their counsel. We were informed that the governor's office was going to come out, or the state was going to come out with some FAQs with regard to what can be asked, but I don't think we've seen that yet.
When the public health order that it came out, we've asked a couple of times related to FAQs and guidance for businesses as it relates to, in the public health order, it states that businesses for their employees have to demonstrate being vaccinated. Well, the question is, how do you do that? And that's what you're asking. The state said that they were going to come out with some FAQs and some guidance on that. But what they were not recommending is to keep records of vaccination, like for my vaccination card to my employer. But one part of the conversation was, have a spreadsheet and see who's vaccinated. But there hasn't been anything that has been put out clear on that topic. So I mean that's a reoccurring theme as it relates to the questions that you're asking.
Okay, and that has to do with employees, and so it's still a little gray. It sounds like, as far as patrons of a business, restaurant.
What I would say is yes, the state has not given any additional guidance to the businesses on what they can or cannot do with regard to proof of vaccination.
Thank you.
Ms. Whalen, just for planning purposes, we're wondering how much more time you think you would need for the presentation. We're coming up at noon. Would you be willing for us to take a lunch break at 12 and then come back at 1, or is that going to foul up your day? Or
I think what we could do, if you're okay with that, I think that there's some interest just in the variants. Maybe Dr. Johnson addresses that, and then we
could break.
Yeah, if that sounds good. I mean, we can always come back at a later time and provide some updates or take individual questions offline. I think that there was some interest in the variant.
Yeah, we can talk about the variant and then maybe take a break at 10 minutes after 12. And, we've been up here for a couple hours, so we'll take a break then. And we've got about 4 land use issues left to do, but if that would work, that would be great.
I think Dr. Johnson can sum it up in 10 minutes.
Did you have a comment?
No, just a suggestion, perhaps looking at the, looking at the items that you have in items of introduction, none of those are going to be extremely lengthy in any way. So you might want to, while you're listening to this great presentation, you might want to consider pushing through, finishing the agenda, and then ending your meeting and having a leisurely lunch. Just a suggestion.
You know, I think we're going to need a break. So, we'll just, is there a problem calling back the other 4 items after 1 o'clock?
There's not. Staff is here and has been here online or present, and outside people have.
Yeah, we had 2 very interesting presentations that took quite a while. So I'm going to suggest we take a break at 12:10 and then come back at 1 o'clock.
You know, Tom, if I can jump in, I would love to have a little bit more time, not just 10 more minutes, just to be able to ask a few more questions before they leave. Is anybody opposed to having lunch at 12:30 or 12:25 or something like that? It just feels like this is a real opportunity, and several questions I have, I know, and other people do too.
Why don't we do this, Richard? Why don't we go to 12:30 and have a hard stop there and take lunch from 12:30 to 1:30, then come back for the 4 land use items. So that's what we'll do. Thanks for your suggestion. Dr. Johnson, over to you.
So this is a challenge here to be efficient and yet still keep you engaged and entertained at the end of a long morning. So welcome to challenges. We are going to talk first about how COVID-19 impacts the body.
And just for everybody listening, if you would identify yourself and position.
Absolutely. I'm sorry about that. I am Dr. Robin Johnson. I'm Medical Director of El Paso County Public Health. And so when we look at COVID-19, who's operating? What am I? Sorry. I'm trying to make sure I'm up to speed here. So COVID-19 comes in and it actually is going to hijack the cells within our bodies. It has these little spike proteins, which is what we've all heard about, that identifies the marker on the cells in our bodies so it can attach there and turn basically the cell open like a key and then enter. It hijacks our factories within those cells because it can't replicate on its own. It uses our ingenuity within our cells to reproduce until it gets to such a point that then those viral proteins burst the cell and it exits and then is in our system ready to infect the next cell. This is why the infection itself is so potentially devastating, because it actually, in using our cells to replicate, it's killing those particular cells. We know that it enters in through our lungs, right? It's a respiratory virus, so it comes in through those droplets. We breathe it in, and it begins by replicating within the lung system. But it also is an endothelial virus, meaning that it gets into our cardiovascular. So we'll see it affect our heart and then vessels, which is why when you're in the hospital and people are having a more severe infection, we can see people have renal failure. It affects their neurologic functioning and memory. It is classically involved with our smell, right? I mean, we haven't completely dissected exactly why it is so impactful in smell and taste, but that is another area. And you'll see it in other vascular areas, like even in the skin. So there's certain rashes that are associated, chilblains, and some other things that are of interest. Next. So Dr. Kelly was going to come and show you these particular slides. And I believe this is the dissection of a set of lungs that are actually healthy. And they are nice and light looking. You can see that there is a certain aeration to them, meaning that they look like they are these are good looking lungs. Like if you wanted to peek inside, this is what you'd want your lungs to look like. Next slide. When we start seeing COVID interfere, it has now begun to break down those cells within the lung system. And so fluid rushes in, our immune system rushes in. They're trying to eat up those viruses and the particles of cells that have been left behind in this debris. And so these are boggy, heavy, congested lungs. We see that, so Dr. Kelly was speaking to that when we look at viruses, there's been a lot of questions that he's had to field about the death certificates that come across his desk. This is also true for how we diagnose in the clinical setting. And we're looking at whether or not you have coronavirus or what else might be affecting you. And we don't do just one and done. We have these panels and they look at all of the viruses that may be circulating. For public health, this is helpful because we can see what is in circulation. And as we lift the mask mandate, it's not just been protective for our community against coronavirus. We've seen decrease in influenza this year. We've seen decrease in RSV and many of these other para-influenza viral transmitted respiratory transmitted viruses. And so as we lift the mask, we anticipate that we're going to see some increasing incidence in these others as well. This is a beautiful cross-section pathology, like you'd look under the microscope of a lung. What you'll see here is that most of it is air. That is the white spaces. The little lines of red that are just fine and lacy looking are healthy endothelial cells where you're actually just one cell thick. You're picking up oxygen, then getting it into the blood stream, and those cells then are pushing out carbon dioxide and the other things that we exhale. However, what happens when we have coronavirus is this is what that cross section looks like. So on a patient who has died of COVID, this is what the cross section of their lung looks like because, again, we've broken those cells. Those air sacs are filled with debris. They have been congested with all of our immune system trying to get in there and eat it up, and the system just breaks down. Did we go backwards? Yeah, so we're going to move on to the next slide.
Another picture.
What are we doing? Oh, did we do it? Did he do it twice?
Sure.
Okay, well, let's just go here. Let's just go to this one. I feel like I'm on Jeopardy. Sorry.
And Susan, can we get copies of the slides? Mr. Murray would like to have some copies, so if we could get those sent to Sarah, to Emily.
And those, we have those.
We've got them. Okay, great.
To do the presentation today, so we can send them out. They're fairly large, so we may send a share file or something.
Okay.
So I think the important thing to remember here is that unfortunately we are keeping Dr. Kelly in business. When we see continued incidents of the coronavirus in our community, we saw that with our huge uptick of incidents in November and December, there followed hospitalizations and then again, deaths followed that. And while we have seen a significant drop, we have maintained a plateau of incidents. And while the age group has shifted and we are younger, we still see those patients being hospitalized. And unfortunately, we still follow with fatalities, and that is persisting. So, next slide. Questions?
Were you going to comment, Dr. Johnson, about the variants?
Sure, I can speak to those. We know that there are variants of interest. So as we've been following the coronavirus, as all viruses, the life cycle of a virus includes that it will mutate. And the mutation is the virus itself really finding its niche and improving that ability to find the next host and to find that sweet spot where it really can invade, but not necessarily kill the virus. So when we looked at the first SARS and MERS, they were actually too fatal. And that is why, while they had outbreaks, they didn't spread in a global fashion because the fatality rate was so high. SARS in COVID-19 has kind of found some of that sweet spot where it has enough transmission, but not such a high fatality rate that it can just keep moving. And we've seen that happen across the globe. As we give it the opportunity to spread and find new hosts, it has the opportunity to try to perfect its life cycle so that it can even be more effective. And that's what we call the interest, the variants of interest. When they become variants of concern is when we see that these particular variants have more transmissibility or potentially more severity of disease and fatality. Those variants of concern that we would be following would be P1, that has happened in, that we have seen evolve out of Brazil, the B117, which came out of the UK, and then there is the B1617 and some others that are coming out of India. The UK variant right now is the predominant variant that we see in El Paso County. However, we do find that there is P1 and the, again, Brazilian, and as well as the Indian variant in the last couple of weeks has now popped up here in El Paso County. At this time, they are more transmissible. We do know that. We are continuing to follow them around their severity. And a lot of the severity that we see in some of these other countries is because of the number of cases, right? We're overwhelming the healthcare systems. There's not the accessibility or resources. It does appear that some of these variants do have impact on some of the treatments, particularly monoclonal antibodies. We see that the efficacy of the vaccine may be a little bit decreased, but we're not seeing that it is overwhelming vaccine immunity. And so again, it really emphasizes the need to get vaccinated and to get a large saturation of our community vaccinated.
Okay, Mr. Scorman's got a couple questions, so we'll go to him now. Richard?
Yeah, Dr. Johnson, thank you all. This is really interesting. I think we're all junior microbiologists these days, so it's really fun to look at all the slides that you have. And yeah, I guess the question, I'm in a particular situation where I have, my wife and partner is yet to get vaccinated. She will, but we wonder how. And I am fully vaccinated. We wonder how risky it is for me to be out and for me to be sitting next to somebody and talking to them who I know isn't vaccinated, or to be in situations where there may be several people that aren't vaccinated. I just wonder if you had any advice on that.
Sure, I'll start, and then if I miss something, Stephen can jump in here too. But we really, those are really important questions, and as noted, this is a novel virus, so we are still gathering that data, and yet there is increasing evidence that not only is the virus protective for you from getting the infection, we do see that there are a very small number of breakthrough infections, but when there is that breakthrough infection, the likelihood that you would have severe disease is significantly decreased, and we still see at this point a 100% prevention of fatalities. I am not aware, and Stephen might have more up-to-date data, but we are not aware of anyone who's been vaccinated who has actually suffered fatality. Now, in light of the question for your partner, is that because of you're vaccinated, even if you were to get infected, you don't produce the viral loads that allow for the spread of the virus in the same way. And so the likelihood that you would become a carrier that could potentially spread it drops dramatically. And so
not much of a risk, but maybe
not much of a risk.
Small,
Nothing I mean, there's only a couple of things in life that are completely right. We are born and then we die. And my children will tell you, you pay taxes in between. But otherwise, yeah, I think that it's a significantly reduced risk. And because of your vaccination, you are really protecting her.
Stephen, did you have a comment?
Actually, she's right on. I mean, it's not zero risk, but it's greatly minimized risk. And with regard to the variants from India, you know that we're just learning about them, really characterizing them. But the UK is a little bit ahead in this game. They sequence an awful lot of their disease and specimens. And the good news is that it appears that the existing vaccine inventory remains effective, perhaps not as wonderfully as effective on the original virus, but quite effective. The bad news is that the Indian variant may well be more transmissible. And, you know, Dr. Johnson mentioned the B117 from the UK. It's now the predominant variant here. And when we say predominant, it's more than 80% of the infections. So if in fact this virus from India, what is it,
1617.
2, yes. If it in fact is more infectious, even though it's quite little of it now, it's bound to become interesting. Of course, more infectious means more infections, which means vaccines are ever more important to help defend.
Richard, still over to you. What else do you have?
Well, you know, I just wondered why there hasn't been a campaign, and you may know a good reason why, but you know, why people aren't saying I'm vaccinated. You know, we see these little buttons, I voted, and it would certainly make everybody feel more comfortable. Is that something that's ever been proposed? I mean, you know, it's just like, as a store, you know, we could give away the buttons. I don't know.
Well, I got one at
Yeah.
King Soopers when I got vaccinated. I got a little sticker. So
Oh,
Well, the stickers wash off though, so we'll let Susan talk to that because we are excited about this potential.
So we do have, just as a refresher, and this is kind of not to your question, but a little bit of it. We did launch a Don't Wait, Vaccinate campaign, and Kim Melchor on the city team, she has helped lead that effort. So we are, you know, further evolving that campaign. And as part of that, we do have stickers at numerous different clinics that say, you know, I have my COVID vaccine, but it's a sticker and it doesn't last that long. So we are in discussions about buying buttons related to, I received my, you know, COVID vaccine. So that will be part of that, Richard. So I think that, you know, that's a little bit of a slow process, but that is in the works.
Okay, yeah, because you know, that seemed something that's possible. And then, what about you know, my question earlier? Is there hesitancy in the military to get vaccinated?
So with that, we had a Major Vass present with us last week at the Board of County Commissioners, and he talked about all of their strategies and outreach on Fort Carson. And what they're finding is that what we're finding, the mobile vaccination access and going to meet people where they are is much more effective at this point, and that's where they are right now. But they're experiencing the same challenges as the community as a whole does.
Yeah. And then, you know, is there any legal issues with requiring vaccines? You know, we have a number of employees, and we thought, well, maybe we should just require vaccines for people to work. We could certainly give them a bonus or something if they want. But is that something that has legally challenged? I mean, I should have had the lawyer come up and answer that, but.
So that is doable if a business wants to create policies to require vaccination.